Myself, Dr. Philips Rautrai. I'm working as a consultant diabetologist at Dr. Mohan's Diabetes Specialty Center, Bhubaneswar. Please. Today I'm going to talk about a case. It's a case-based discussion basically. So, Mr. AB, a 58-year-old with a history of type 2 diabetes since last 4 years, with obesity, hypertension, hyperlipidemia, and obstructive sleep apnea. On physical examination, the body mass index stable at 32 kg per meter square, blood pressure 130 by 82 millimeter of mercury with a heart rate of 60 beats per minute. On the laboratory measurement, his HbA1c or glycosylated hemoglobin is 8.3% with the eGFR of 70 ml per minute per 1.73 meter square of body surface area, with LDL cholesterol 69 milligram per deciliter, with HDL 35 milligram of deciliter, and triglyceride 250 milligram per deciliter. On LFT, the AST ALT ratio 70/100. The patient, Mr. AB, currently on medication of metformin 1000 milligram twice daily, lisinopril 40 milligram once daily, metoprolol extended release 100 milligram once daily, atorvastatin 40 milligram once daily, and aspirin once daily. If you look at the patient profile, he has a short duration of diabetes, that is 4 years. He is young and has no major comorbidities with no major complications that would reduce his lifespan. He is at low risk for hypoglycemia. He would benefit from a more stringent goal. However, he is also obese, hypertensive, hyperlipidemic, with obstructive sleep apnea and disorder. So the ADA or the American Diabetic Association recommendation is HbA1c less than 7% is a reasonable goal for most non-pregnant PC. The following considerations also predominate in determining the pharmacotherapy for him, such as the low risk of hypoglycemia, weight loss or minimized weight gain, heart failure, atherosclerotic cardiovascular disease, chronic kidney disease, and of course, cost. Mr. AB is willing to start another medication but is concerned because he sometimes forgets to take his pills and fears that the additional pills will only make this worse. He doesn't want to have injectable therapy. The fixed dose combination or FDC may improve the patient adherence by once daily dosing, less complex treatment regimen, fewer pills, improved side effect profile, and adherence. The people with type 2 diabetes, they commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common. The monotherapy cannot address these multiple defects and often leads to failure to maintain the glycemic control over time. Current diabetes guidelines encourage the early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. American Diabetic Association recommendation that in appropriate high-risk individuals with established type 2 diabetes, the decision to treat with a GLP-1 receptor analog or an SGLT2 inhibitor or sodium glucose transporter inhibitor to reduce the major adverse cardiovascular effect, the hospitalization due to heart failure, CV death, or chronic kidney disease progression should be considered independently of baseline HbA1c or individualized HbA1c target. So now in this case, the empagliflozin and linagliptin combination is available as first-in-class treatment in SGLT2 inhibitors and DPP4 inhibitor combination group of drugs. Now, the SGLT2 inhibitor is a class of novel oral glucose-lowering agents that mediates glucose-lowering action by increasing the urinary glucose excretion via inhibition of the sodium glucose cotransporter 2 in the proximal tubule of the kidney. The salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of the disease course. The DPP4 inhibitor exerts its glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of the glucose dependent insulin secretion and inhibition of glucagon release. The combination of these agents has potential to show the additive glycemic control due to their complementary effects. Empagliflozin cardiovascular outcome event trial in type 2 diabetes mellitus patient, that is the EMPEREC outcome trial, has reported that the 3-point MACE outcome occurred in a significantly lower percentage with a hazard ratio of 0.86 in the empagliflozin arm compared to placebo on top of standard care. In addition, the cardiovascular safety of linagliptin, a DPP4 inhibitor, was further elucidated in Carmelina and Carolina trials. The HbA1c decrements by this combination of EMPA and LINA has demonstrated a 1.81 percentage HbA1c reduction at HbA1c baseline of more than 8.5% at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained at week 52 in metformin treated groups, and a higher percentage of patients achieving the HbA1c less than 7% were reported for combination. The combination offers a suitable component in strategy to achieve the target A1c without increase the risk of hypoglycemia and weight gain, with the improvement in overall lipid profile, a reduction in the incidence of genital infection associated with SGLT2 inhibitor has been reported when a DPP4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. So, in summary, the EMPA-LINA combination provides a robust HbA1c reduction and a 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individual agents with low hypoglycemic risk. Thank you.